All right. Good evening, everyone. We are live. It's been a really long time since we've done a Critical Conversations webinar. So, welcome back. Happy New Year. Thank you for joining us. I know that my phone has been blowing up, and I've been seeing the comments on social media. A lot of us are super, super excited about tonight's topic because you guys know, like, we've talked about the fact that reproductive health often flies under the radar, but I feel like this subtopic within reproductive health is even more so understudied, underfunded, under-resourced. So we are really, really excited. We have a hematologist from UIC who actually runs the adult clinic at University of Illinois. Her name is Dr. Farooqui, and we've been tracking her down, like stalking her for the longest time. A lot of you, I think, blew me up when you heard her present at SCDAA or I don't remember what conference, but since then we've just been in communication and we're able to lock her down for tonight. So I'm going to get out of the way because I know she has this amazing presentation, I think like just under 30 slides. So I'm going to be learning right along with you guys. So Dr. Farooqui, if you want to take it away.
Thank you, Tiana, for having me on this platform. I'm really excited to be here and share my work. I've been, talking about this for the last at least 2 to 3 years. So, today is really unveiling some of the new stuff that we've been finding in our research and some of what I presented at ASH from our most recent findings. So, the as Tiana mentioned, I'm a assistant professor and a clinical uh, attending over at the University of Illinois in Chicago. I do adult hematology with an interest specifically in sickle cell and women's health. So, without further ado, I wanted to start talking about menopause in women with sickle cell disease because this is usually not talked about, and in the last 2 to 3 years, it is picking up some traction. So, my goal is to review existing knowledge of what menopause is with our viewers, as well as understand what happens with menopause and sickle cell disease, or the little that we know about what happens in menopause with sickle cell disease. Discuss evidence of early onset of menopause and what contributes to this, as well as identify challenges in recognizing and managing menopause in this particular population. And towards the end, I hope to propose strategies to improve care around the menopause transition for women with sickle cell disease. I have no disclosures and a little bit of background, as you guys already know. The lifespan of individuals with sickle cell disease has been gradually increasing. Yay, right? But with this, we have to start thinking about it as a lifespan disease and issues of aging. So really, there's a lot being done in terms of cardiac health, renal health. Even in women's health, there's been quite a lot of progress that's been made with pregnancy and menarche, but really there was not much on menopause. And one of the biggest reasons was up until a couple decades ago, our patients did not even reach menopausal age. So no one really studied it. And one of the first people to study it was someone out of Brazil. And that's kind of where they started noticing that patients with sickle cell disease, particularly, do undergo menopause perhaps a little bit earlier than the general population. And this really goes hand in hand with Dr. Pecker's findings from Hopkins. And, she always talks about how the ovary is an end organ. And, when you put those two pieces together, you realize, yes, menopause could potentially happen early in this patient population. So, for me, honestly, a lot of research. I'm a clinician first and a research scientist second. So all of my research is really clinical research. Although because of my research, I've started dabbing a little bit into lab and bench research, but really my heart's with the clinical stuff. So honestly, this whole research idea started because of one of my patients who asked me that if she was going through menopause symptoms. And at that point, I was taken aback and I was like, I haven't even thought about menopause in several years. We kind of browse through it in medical school and we don't really learn about it much as physicians. And if you're trained in internal medicine and hematology, you barely, think about it and talk about it. And then I reached out to my OB-GYN colleagues, and they had the similar experience. Even though they're gynecologists, they don't really talk about menopause as much either. So this isn't just true for sickle cell, this is true across the board for all women. There's not much information available on menopause. Granted, in the last half decade or so, we've really, started talking about menopause. But specifically in sickle cell, there was nothing when I first started. So I did a little bit of literature review, couldn't find anything. So I told my patient, you know what? I don't know. I don't know what to expect. I don't know how you're going to transition, but some of your symptoms do sound like menopausal symptoms. So we now 4 or 5 years later, now we know a little bit more about it, and I really give credit to her for bringing this idea to the forefront and initiating this journey for me. So the definition of menopause, initially when we started this study, I reached out to providers who were hematologists. I reached out to providers who were internal medicine specialists, and I reached out to patients. We did a brief survey to see how knowledgeable is everyone, the key stakeholders, how knowledgeable are they about menopause. And I realized quickly that we, as physicians and patients, don't really have much knowledge about menopause. So before I get into more details, I want to talk to you guys about what menopause is. So menopause is a natural transition of every woman's life. So essentially, you can undergo menopause either naturally when your estrogen levels decline, or you can have iatrogenic menopause when your ovaries are removed surgically. Um, when women undergo menopause, they do experience significant symptoms, and this transition period is called the perimenopause period or menopause transition. And this period specifically can last several years. I've heard reports as much as 10 years before your final period, you could start feeling some of these symptoms. And then after menopause, that's another Pandora's box that no one really talks about. As women age after menopause too, there's lots of symptoms that don't go away, but because of our culture, because no one talks about menopause, the patients aren't bringing it up with us either. So really, we have to know the definition. We have to know that, what are the symptoms associated with it. So my goal for this talk specifically is to leave you guys with, what happens a little bit before menopause, what happens during, and what happens after. So basically what happens is you have a significant decline in your estrogen levels, and then you stop having your period. You have to have no periods for at least 12 months, and that is when you're officially in menopause. It can't be, I haven't had a period for 3 months, but then it came back. It doesn't mean you're in permanent menopause. So it has to be that 12-month end of fertility period. And it typically begins with changes in your fertility in terms of, having fertility issues. It also starts with changes in your menstrual cycle. So that's one of the first things that women will talk about. They'll say, my periods are starting to get irregular, or my periods are starting to get heavy. So that's kind of the first sign that you notice of menopause. And hot flashes is something else that follows rather soon after that. Um, so now that you guys understand the menopause definition and what comes with menopause, I want you guys to understand some basics. So in the United States, the average age of menopause, based on this national study that went on for years, it was a prospective study, the average age was about 51 to 52 years of age. The World Health Organization also did a prospective collaborative study, and it was noted that menopausal age is anywhere from 49 to 52, 49 more in the lesser developed countries, and closer to 52 in Europe as well as the United States. So, in sickle cell specifically, the Brazilian study found that menopause age was experienced by sickle cell patients around ages 46 to 48. This was definitely earlier than the average patient population in Brazil, who experienced menopause closer to 52. So they were experiencing menopause about 4 to 6 years before a non sickle cell disease patient in Brazil would experience. And in the United States, within our institution as well as at Jefferson Health, when we were looking at some of the data, we also found similar results that women in our cohort were also undergoing menopause a little bit earlier. And this was around very similar to what the Brazilian study was finding in the age range of 46 to 47. Um, so it's really important to understand why menopause is important in sickle cell disease. It's not just fertility that we're talking about, but fertility is something that is important, especially if you're going to undergo menopause early. Some women, in fact, are starting to see decline in fertility as early as their mid 30s with sickle cell disease. And this is huge, especially because we already know that women with sickle cell disease have a shortened fertility window. Dr. Pecker's study did show that there's decreased ovarian reserve compared to age matched cohorts. And then there's concerns about treatments such as hydroxyurea, stem cell transplants, also decreasing fertility in our patient population. Some of the symptoms of menopause that the average woman deals with, regardless of whether or not you have sickle cell, um, are brain fog being one of the big symptoms. Hot flashes is huge, both in sickle as well as non-sickle individuals. And then you have mood changes, vaginal dryness, decreased sexual libido, increased fatigue, increased joint aches and pains. And as I'm going through some of these symptoms, you guys are probably thinking, hey, some of this overlaps with sickle cell disease, right? So, how do we know if this is sickle cell versus menopause? We don't. Um, so that's my question. How do we distinguish whether some of the symptoms that our women are reporting, whether it's in clinic, whether they're when they're admitted to our hospitals, is it because of menopause or is it because of sickle cell or is it both? And should we be doing something about it? Are we under treating or over treating one or the other thing? So that's really where some of my research comes in. So, some of the common symptoms that I've noticed in patients with sickle cell disease, and this was looked at both in the Brazilian study as well as our own internal study, we noted that a lot of these patients had hot flashes, sleep disturbances, depression, and anxiety. And in our cohort, we had the same issues. We had hot flashes, sleep disturbances, and joint pain. About 80% of the women in the Brazilian study reported decreased severity of sickle cell pain after menopause, which is promising, right? But the pain may go away. However, organ damage does significantly increase regardless of whether or not you have sickle cell disease, because as you decrease your estrogen levels, your cardioprotection goes away, your bone density, you start having issues with thinning of your bones and a lot of the other issues. So there may be a trade-off between pain and other end organ damage. So that's something important to keep in mind. And what we did is we looked at our cohort and compared it to the SWAN study that was done in the United States. And we specifically noted that compared to the SWAN study, even our patients specifically were experiencing more hot flashes, sleep disturbances, as well as joint pain. So, as I mentioned, there's quite a lot of overlap between both sickle cell disease as well as menopause symptoms. I'm not sure what is that on your end, Hannah?
What happened?
Oh, I was getting some feedback. I'm
Oh,
sorry. Um, so there is quite a lot of overlap between both menopause and sickle cell. When I talk to my gynecology colleagues, they say, it doesn't really matter. If you have hot flashes, treat the hot flashes and see if the sickle cell gets better. So that's kind of, our strategy of thinking about this. But the question is, are we is it safe to treat some of these menopausal symptoms in individuals with sickle cell disease? We don't know. We don't have enough data uh, to start treatment versus not starting treatment. So that's really where some of the gaps come in. As I mentioned, a lot of it is because we ourselves as providers lack information about menopause in general. And then on top of it, we don't have enough information on menopause and sickle cell disease. There's no screening and guidelines in terms of sickle cell disease. I know the National Alliance of Sickle Cell Centers is working really hard to come up with some guidelines and some screening strategies for sickle cell patients, but we have yet to talk about menopause in these guidelines. Same goes for the American Society of Hematology as well as the World Health Organization. Pretty much we're focused on the early years and we're focused on some of the other organs, but we're really not focusing on the menopausal health of these females. So that's something that I hope changes in the next coming years for us. So we decided to start from the beginning because really there isn't much going on. So uh, when we started this research about 4 years ago, there wasn't much happening in the sickle cell disease space. So we decided, let's do some exploratory work. Let's start with old-fashioned surveys, and that's kind of where everything started. I started some basic educational surveys at the UIC cohort as well as collaborated with Dr. Odinaji as well and Dr. Pecker to get longer menopause questionnaire surveys as well as quality of life surveys in our sickle cell cohort between Hopkins, Duke, and UIC. And that's kind of how we started getting some more information about what really happens in various women with sickle cell disease and various subtypes of sickle cell disease as well. What we did at our institution at UIC is we used a quick screening questionnaire that was developed by Dr. Goldstein in Canada and a primary care clinic to screen women for menopause transition symptoms. So we used that questionnaire and we adapted it to sickle cell disease to fit it into the patient population and what would be more important. So our community advisory board, patient feedback, provider feedback, and then some gynecology menopause experts helped us to adapt this questionnaire. And we started utilizing it in our clinic over the period of about a year and a half or so. So, what we did to the original questionnaire is we left it alone. We wanted to keep it easy. It was a 6-question questionnaire. We ended up adding just a couple pointers that we noticed were consistently missing in the documentation. So last menstrual period surprisingly was missing quite a lot in our clinical encounters. So I really wanted that documented somewhere because this is important. We need to be asking about last menstrual periods, not just for pregnancy, but also for fertility issues. So that's something that we decided to add on there. And then when I was asking about change in periods, a lot of the women were on birth control or they've had salpingo oophorectomy where their uterus and ovaries was removed, or they just didn't have periods anymore. Whether they were postmenopausal or not, they didn't know. They just, one fine day, they just stopped having periods and didn't really think to talk about it with anyone. So I wanted to, after discussing it with some of the patients and some of our community advisory board, we decided to have more details about that specific question regarding the periods because we noticed there's quite a lot of variability with periods when it comes to patients with sickle cell disease. And then we added a second part to the questionnaire, and we wanted to understand the impact of menopause on sickle cell disease. And who would know about the impact of menopause in sickle cell disease more than the patients themselves, right? So we wanted to see if they were experiencing any of these menopausal symptoms. Did their disease change? And how did it change? And did these women think that any of these symptoms were related to sickle cell disease? Were they unsure? Or they said no. So we were pretty successful implementing this survey in our patients, a quick questionnaire over the year and a half, and we were able to survey about 103 patients, which was pretty nice. We looked at specifically adult women ages 30 to 65. Again, initially we started at 35, and then we started noticing that some of these women stopped having periods at age 37. So um, after talking to some of the menopause experts, we decided to decrease the age for the questionnaire to age 30 because we wanted to capture the perimenopausal period, especially if the transitioning was happening as early 30s. We wanted to capture that cohort as well. So this is a single center study with hopes to expand into the regional area in Illinois. We adapted the questionnaire, as I mentioned. We also added some chart review data as well, looked at demographics, looked at hemoglobin subtype to kind of classify if there was, some certain symptoms associated with certain subtypes. We looked at disease severity and specifically looked at biomarkers, retrospective biomarkers. Um, Hemolytic markers were important, as well as iron and reticulocytes. We looked at baseline hemoglobin as well in some of these patients, looked at disease modifying therapy use. At the time of the study, voxelotor was still on the market, so we did include voxelotor on there. And then if the patients were on opiate medications, if they were on neuropathic pain medications, because neuropathic pain medications are also used to treat some of our menopausal symptoms. And then basically we used the SWAN cohort to compare the symptoms that our cohort was experiencing with the SWAN cohort. And we did some descriptive analysis as well as some more fancier statistical analysis that my statistician understands way better than I do. So our demographics, we ended up analyzing 101 patients. Our average age for our patients was 44. And keep in mind, this isn't age of menopause. This is the average age of our cohort. The average hemoglobin was 8.9. The LDH was around 350. Reticulocyte count was 173. Ferritin was on the higher end, 829. About half of our cohort was on hydroxyurea therapy. Only 10% was on chronic exchange transfusion. 7% was on voxelotor. L-glutamine use was not as prominent in our cohort, about 2%, and this is true for most adults because of the compliance issues. And then about half of our patients were on opiates, and about 21% were on neuropathic pain medications. So of the patients that we analyzed, we noticed that patients were having, we essentially got totaled the symptoms from the questionnaire and realized that our mean score was 1.85, which means that they are having moderate symptoms for menopause. And the most frequent symptoms, as I mentioned, was hot flashes, sleep disturbances, and joint pain. Symptom burden increased with age, especially once you hit that 40-year threshold. And interestingly, symptom burden also increased with higher hemoglobin levels. So the non-SS hemoglobin subtype had more symptoms of menopause. And symptom burden actually decreased with use of disease modifying therapy, which was, consistent with what we had hypothesized. Uh, and then the higher symptom scores that were observed, we noticed that the patients with higher scores were already on neuropathic pain medications. Now, we don't know if the symptoms triggered their providers to put them on neuropathic pain medications versus, they were on it. That's why they were having more symptoms. We don't know the relationship or the causality for that. And we did note importantly that there was no significant relationship between symptom burden and hospitalizations, fortunately. No significant relationship between chronic pain and daily opiate use. So at least that was reassuring because that is something huge, right? If we're treating menopause related symptoms with opiates, that's probably not a good idea. So, at least in our small cohort, that was something reassuring, but it needs to be validated with a larger cohort for sure. So, we did notice that compared to the SWAN study, the Black females in the SWAN study versus our own study cohorts, our patients definitely had significantly more hot flashes. They had slightly more sleep disturbances as well as slightly increased menstrual changes and mood disturbances as well. As I mentioned, patients with who were older had more had a higher MQ6 score, and the higher scores were also seen in patients who were not on any disease modifying therapy. So the next part of the study, which is currently undergoing, is, I've come to you with saying, these are all the symptoms. There's quite a lot of overlap between menopause and sickle cell disease. So the question is, how do we know what's menopause and how do we know what's sickle cell disease? So this is where we really need to look at some biomarkers and in our perimenopausal cohort, the patients who are having symptoms versus the patients who are not having symptoms. So we are collecting some endocrine data on our cohort and running some studies in that to see if there is any signal that we can find early to, kind of gauge who will have more symptoms, who will have earlier menopause. Because if we're able to predict that, that will really change the management in some of these patients. So, I really hope that the WHO and some of our national societies do take up menopause in terms of their guidelines. Recently, last year, the WHO released some pregnancy guidelines as well as postpartum guidelines, which was a huge victory for our women with sickle cell disease. And I'm hoping that they start incorporating menopause in these guidelines as well, because this is something that can't be ignored when 50% of the population is bound to deal with it regardless. So, um, as I mentioned, there are research gaps. We need to train more sickle cell disease specialists to start thinking about women's health, not just women's health, but also menopause, which is, in the midlife spectrum. Uh, it's not something that we worry about in the geriatric population. These are middle-aged women who are having real symptoms. We need to address these symptoms appropriately. And we also need to look at what can we do about these symptoms, because the standard menopause therapy that is proposed in non-sickle cell patients is typically hormonal management of hot flashes and some of these symptoms that patients deal with. However, hormone therapy can be risky for patients with sickle cell disease, especially because it predisposes you to higher blood clots. So we need larger clinical trials to see if transdermal patches would be safer in these patients. Likely safer because we have some data from our contraception use that this tends to be better. But there's also a lot of menopause management drugs that are coming out that haven't been used in sickle cell patients. Will they be safe in sickle cell patients, or will they help alleviate some of the symptoms that they're facing? We also don't know how early menopause impacts their bone health, the cardiovascular health, their neurocognition impact. We know menopause itself in the average woman causes a lot of brain fog as well as increased uh, risk for Alzheimer's and things like that. With our sickle cell patients, our patients are already a little bit increased risk for dementia as well as other neurocognitive impairment because of silent strokes. We need to make sure that menopause isn't adding to this burden for our female patients specifically. So these are some gaps that do need to be addressed, and I hope in the next decade, as we all age with sickle cell, we're able to answer some of these questions that have not been answered. And we really need to work on this collaboratively. The reason my project has been successful thus far, it's not just me, it's been a team of my colleagues, not just my mentors, but also my patients who've given me feedback on my survey, who our community advisory board, who has worked so hard to give us feedback and ideas of how to implement this, and our most importantly, my physician colleagues who've helped implement it in our clinic. With that, I would like to acknowledge my mentors, Dr. Goba and Dr. Sue. Dr. Sue is the reason why I'm in sickle cell, and Dr. Goba is my gynecology mentor who really has, changed my career trajectory. Dr. Saraf is also one of my directors who's helped me quite a lot to especially learn about bench research, because that's something that I wasn't really an expert on, and some of our implementation scientists as well. So we're fortunate to have a good team, and I'm happy to be working with other leaders in this area of women's health and reproductive health across the United States. Please feel free to reach out to me if you have any questions, and I can uh, open the floor for questions.
Oh my gosh, that was amazing. Just like so robust. I feel like I learned so much. Just like every slide that you presented, I had like a question and feedback. So there's already some questions in the chat, and you guys feel free. We have about 15 minutes to take questions. So if you have not already put your questions in the chat, please feel free to do so. Okay, well, I'm gonna start because just before I forget, like some of us have been put on depot. Like before my bone marrow transplant, I was put on depot because they just did not want me to obviously like bleed during the process. And I was having like the hot flashes and all like that as well. And I'd always say, like, well, they pushed me into menopause. They pushed me into menopause. But then when I was looking at like the formal definition menopause is, because in my mind that was like iatrogenic menopause, but it sounds like if you know that if you did not lose fertility and it's expected that your period would come back, it was not accurate of me to say they pushed me into menopause.
Yeah, so that's actually a really good question that comes up quite a lot. So there's two parts to your question. One of it is, does being on depot or long-term contraception put you into menopause? No, long-term contraception just controls your hormones and controls your period. So it doesn't necessarily put you into menopause. What puts you into menopause is an insult to the ovary. So let's say you had an ovarian torsion and they had to go in and remove your ovary, or you have ischemic damage because of low blood flow to the ovary and they had to go in and take out your ovary. Now, specifically in the case of transplant, the the treatment that is given prior to transplant, the conditioning regimens, those are really toxic to the reproductive organs, and those will most of the time put patients into menopause. So more likely than the depot, it's usually the conditioning regimen that's used. And that's why before transplant, we always, start talking about fertility and fertility preservation, referring patients to fertility clinic where, they can start thinking about saving their eggs, or, sperm banking specifically for males before the transplant. So that's a good question.
Okay, thank you. So let's get some of our questions in the chat. Do you there like an average number of years that menopause lasts? Somebody's wanting to know like how long is usual to stay in perimenopause and how long for menopause.
So perimenopause is the period right before menopause, and then the date of your final period and a couple years after. So this entire phase can be about up to 15 years. And keep in mind, let's say you went through menopause at 50.
Mhm.
At 65, you're still going to be experiencing vaginal dryness, vaginal atrophy, right? So no one talks about all of those things that 65-year-olds are experiencing. So once you've experienced menopause, it's a downward decline from the estrogen standpoint. But the hot flashes do get better once you're after menopause. It's really the pre-menopause time, the perimenopause time, right before your final period, is where you're dealing with the sleep disturbances, the mood swings, and the hot flashes. But really, some of the genitourinary stuff, such as urinary incontinence, the vaginal dryness, that stays with you for a long time, and it's an irreversible process. So we do need to address those issues medically.
Okay, thank you. You had mentioned that, like, some of like the hormone therapy could increase risk for clotting, particularly in this population. So, there's a question about, is there anything like supplement wise that could help with like hot flashes and symptoms?
So there are certain supplements, especially soy-based supplements, that can help with symptoms. You just have to be careful with the herbal supplements that you're taking, because these are over-the-counter supplements that can have an effect on your liver as well. So if you're going to be taking supplements, which some of my female patients do, and they do help them, just talk to your sickle cell provider about it so they can keep an eye on your liver and your kidneys while you're taking these supplements, just because they've not been tested by the FDA. But, word of mouth is out there. There's a lot of things that we know that do help in menopause. Can I officially say it's safe to take in sickle cell? No, because I don't even have any medications that I can say are safe to take in sickle cell. And that's where we're hoping to go. We're hoping to do some clinical trials to establish the safety of these supplements that majority of the women across the United States are probably taking for menopause without even talking to their doctors. But we need to make sure that they're safe in sickle cell patients. And going back to the supplements question, until I started getting into this study, I never asked my patients, hey, are you taking any herbal supplements? You'd be surprised how many patients out there are using herbal supplements. Some of them are even using supplements with iron in them, which could be very dangerous, right? So this was an eye-opening experience for me. And we have a pharmacist in our clinic. And the pharmacist never even thought about, asking about specifically herbal supplements. But it is a thing out there, and really talk to your doctor about it. If it helps, then yes, you could potentially use it safely as long as it's being monitored by your physician.
Yes, definitely, guys. Make sure you keep that line of communication open about supplements. I know for me, I think it was like last year or 2 years ago, I started taking like this herbal fertility tea, having no idea that it was actually interfering with my clotting factors and totally canceling out my blood thinner. So be careful with those. Definitely talk to your doctor. I don't know if Lydia Pecker's on here, but she was my doctor at the time, and that was crazy. So just another warning, make sure that you're talking to your doctor before you even start taking the supplement. Somebody wants to know, what was the reason behind symptom burden and decrease in the patients on hydroxyurea?
To be honest with you, I don't know. That was an interesting finding. But we also found that the women who had a higher hemoglobin had more symptoms.
That's
So could it be that the hydroxyurea is increasing your hemoglobin, and that's, you're overall in better health, and that's why you can pay attention to some of these symptoms, versus patients who have much more severe disease or focused on sickle related symptoms and not really, reporting some of these menopause symptoms.
that's fascinating. I know one thing that we can all appreciate is just like the fact that you are so comfortable in just saying like, I don't know, because that every provider is not like that. And we definitely are in support, and however we can help to get you some good funding, because there's just a lot of gaps, a lot of questions. You And that there are gaps that exist in research, education, and care. Any ideas on how advocacy organizations can help close that gap?
I think being aware of menopause and being aware that, this is not being discussed. Like, just ask yourselves, how many times have your doctors, whether it's your sickle cell provider or even your gynecologist, has even brought up end of fertility with you, right? So I think each individual advocating for themselves, and then as organizations putting it on the agenda, whether it's a platform like this, or um, we a lot of sickle cell annual meetings come up throughout the year, throughout the nation. Putting that on the radar of both policymakers as well as providers, and most importantly, our patients is important.
Thank you. Feel free, guys. We still have a little bit more time. I see two more questions. Um, okay. So, can someone in their 60s, and I'm not exactly sure exactly what you're trying to ask, but I don't know if she's asking, is it possible that she's in her 60s and still going through it, or if she's asking about being late to start it. So maybe just answer both.
So typical age of menopause is around 52 to 54. Um, in my experience, I have not met any woman who's gone through periods till the age of 60. But again, I'm not a gynecologist, so take that with a grain of salt. Now, one thing I do want to let everyone on this know, it's kind of like a public service announcement, because I'm a hematologist oncologist as well. Some women go through menopause, they stop their periods completely, and 5 years later, they start getting vaginal bleeding, right? Let's say they're 60 or 65, and
Wow.
they think, oh, my period's coming back. But it might not be your period coming back. It might actually be something's wrong with the uterus. So it's important to get that checked out. After you haven't had a period for 12 months, if you do get vaginal bleeding, there might be something else going on. So that's something that I do want to let you guys know. In terms of the other part of your question about menopause, can you have menopause transition, maybe symptoms at the age of 60? Yes.
Mhm.
Especially if you went through menopause a little bit later, you may still have some of the symptoms such as hot flashes, mood disturbances, sleep issues, joints, aches, and pains. But remember, there are certain symptoms such as vaginal dryness, worsening bone density. Those kind of things never really go away. Urinary incontinence. Those actually keep getting worse as you age for females. So that is something that we need to address with gynecologists proactively.
Mhm. Okay. Are alternative treatments recommended in the case of chemopause? I like that. Menopause due to chemo from transplant when symptoms occur at an early age without any real transition period.
I'm reading that question
Oh,
again,
you can.
sorry. Yeah.
Okay.
Alternative treatments. I'm not sure what they mean by alternative treatments.
I was
Um,
asking more like about supplements, or
Supplements.
can you just
Yeah.
type
I,
in the chat and we'll see it.
I know in the usual uh, population, especially in my oncology population, if we're putting them in early menopause, we will put them on either a transdermal estrogen patch, give them vaginal creams for, vaginal dryness. So we do use other options for menopause treatments that are not high risk for venous thromboembolism. So in this case, it might be appropriate to use some of those studied medications already. But again, they haven't been studied in sickle cell, but we know generally we can extrapolate from the data, from our contraception data, that it's generally safe.
Okay, I'm looking at Courtney's question. Courtney, like myself, also had a bone marrow transplant, and there was some medical gaslighting going on. Like she was going and saying that she was in menopause, and they didn't believe her, which is really weird to me. Because yeah, it's just weird. So, she wants to know, is there something that she should be doing long term? Because she's noticing changes in her joints and bones.
So I don't know your age, Courtney, but I would recommend as soon as women go through menopause, their estrogen levels tank, and your bones need estrogen levels. Your bones need estrogen to stay strong. So I would recommend first and foremost, consider bone density screening at least a year or two after menopause, especially with sickle cell. Sometimes, if you've had several transfusions, you get iron overload, which already predisposes you to thinning of the bones. So, if you undergo transplant or undergo early menopause in your late 30s, early 40s, then it's probably a good idea to start doing bone densities early on, specifically.
Mm-hmm.
And then, in addition to that, cardiovascular health is also affected when your estrogen levels start declining. In patients with sickle cell, usually there's no significant risk for atherosclerosis. In terms of that. However, there is a risk for stroke. So you want to make sure that somebody is monitoring your cholesterol, somebody is monitoring your blood pressure, your diabetes, because as women go through menopause, the risk of getting diabetes, high blood pressure, cholesterol, high cholesterol, all of these things increase and therefore increased risk of cardiovascular disease as well.
Wow, I'm really glad that you put that on our radar because honestly, I didn't think about the cardiovascular aspects of menopause. In Courtney's situation and in my situation, I'm just curious to know, like, I know we don't have a lot of information, particularly in like the curative therapy setting, but like for me, I did not have a period for like 5 years. My hormones were completely out of whack. But then just one day, like everything just normalized. I got my period back. And so, is it possible that Courtney could come back and this is just her body being out of whack post curative therapy, but it's not true menopause?
I know she mentioned that she was put on hormonal therapy as well.
Mm-hmm.
So this quite often happens in my not just transplant, but in my oncology patients as well, right? Especially my young cancer survivors, breast cancer survivors, or, my 30, 40-year olds who haven't really gone through menopause, but they have to go through chemotherapy. They will either intentionally, they'll get ovarian suppression from medication ovarian suppression, or because of the chemo, they may temporarily lose their fertility. And it will, for some, we don't know if it'll come back for everyone, but we know for some patients the fertility does come back after 2 to 3 years. In your case, it was 5 years, but for some of my patients, it comes back after 2 to 3 years, and some of my patients after chemo get pregnant as well and have healthy children. So in your case, Courtney, it might be that it could potentially come back. And I really learned this from Lydia Pecker following the anti-Mullerian hormone. Even though our gynecology friends really don't, like it as much, I really think looking at the anti-Mullerian hormone, uh, even though there's mixed data about it, does help, especially tracking it. I've noticed specifically in my sickle cell patients when their periods start getting all over the place, and especially if they miss periods for long periods of time, you'll see a decline in anti-Mullerian hormone levels. And then, once they start getting their periods back, this is not transplant patients, this is not chemotherapy patients, these are just 40-something-year-old sickle cell patients, you start seeing the increase in the anti-Mullerian hormone. So, for
Yeah.
whatever reason, perhaps probably because of vaso-occlusion, your fertility is slowly declining. But as the ovaries are getting better blood flow, maybe the damage that's done is reversible and you do pick up the fertility. Now, Courtney's case is different and your case is different with the transplant. But I'm thinking it's similar pathophysiology.
Yeah, that's we're gonna pray about that, Court. Um, what I know you mentioned it in your cohort that you had like lowered the age range. Can you just remind us what the earliest age was of a sickle cell warrior who was going through menopause?
So we had 33-year-olds that had some of the menopause transition symptoms. And keep in mind, these symptoms wax and wane. So it might be, at a certain period in time you're experiencing these symptoms, but a year later you're not. Specifically, a lot of my patients, when I start bringing this up, they will go home and make dietary changes, they'll make lifestyle changes. And 6 months later, they come back to me and I do the screening questionnaire again. And they're like, you know what? My hot flashes are better. And I'm like, how? Why? And they're like, I made dietary changes. I changed my lifestyle. I started exercising more. So, there is a lot of lifestyle medicine involved too, where patients are doing it on my own. I'm not coaching them
Yeah.
specifically because I'm not a menopause expert to do that. But there is quite a lot of research that, just lifestyle modifications itself can help.
Okay. Anything that we can be doing on our own to get estrogen levels back?
That's a good question. Honestly, I think the biggest thing that I learned myself from, attending all these menopause talks, I'm not trained to be a menopause expert, is really, as I was mentioning, the lifestyle modifications and decreasing the amount of stressors does help. Easier said than done, right? Especially when you have a debilitating disease such as sickle cell disease, where you can be in pain crises for long periods of time, and that's the stress that you can't control. But at least controlling the stress that you can, that definitely does help, as well as really the diet, the exercise. Some of that does help preserve preserve your health, and also long term helps preserve your bones as well, especially exercise.
Yes, thank you for that. Yes, the recording will be available. It will be on our YouTube channel and then on our website, sicklecellred.org. If you go to our webinars page, we have a playlist of all the webinars that we do, and they go in order. So, by the end of the week, this recording will be housed in that playlist. You guys are asking some really good questions. Whitney's kind of just touching on what you said earlier about the fact that like some of the symptoms can overlap with sickle cell. So, what is your advice? Like, if you're already fatigued and severely anemic, and then you start menopause or that transition, like, what can we do to lessen the burden of anemia?
So this is something that I learned from my mentor, Dr. Goga, who, I this used to come up quite a lot, not just in my sickle cell patients, but also in my patients who have iron deficiency anemia, and patients start having fluctuating periods where they may have like two periods in a month, or they may skip periods for a couple months before they start getting a period again. So their iron levels may be all over the place, and specifically in the case of sickle cell, you a lot of patients already have irregular periods to begin with. Some of them may have heavy bleeding. All right. So the most important thing from my end is to check for other deficiencies, such as iron deficiency, and make sure, even though you have sickle cell, if you're bleeding, you may be losing iron faster than you're able to absorb it. And if you've had back-to-back pregnancies, some of my patients have had 4 pregnancies in the span of 3.5 years. So that also depletes your iron pretty significantly and pretty rapidly. So, just having your provider check your iron levels to make sure, hey, you're not low on something that could easily be supplemented. And once you start supplementing those things and finding those deficiencies, start looking at, can I go and talk to my gynecologist about getting started on treatment for menopause? And I have sent a lot of my patients to our gyne colleagues to get them started on treatment. Some of this treatment is not just hormonal therapy. Some of this is uh, SSRIs, antidepressants. Sometimes you can use clonidine for hot flashes as well.
Oh,
They can get pretty creative, our gynecology colleagues, to try and avoid our hormone therapy. And then for some of the vaginal dryness, the genitourinary symptoms, we can, use vaginal estrogen cream pretty safely in patients with sickle cell disease. Also, I've sent patients to physical therapy for tightening of their for bladder exercises to help
oh,
decrease the urinary incontinence and things like that. So really supporting these patients get through the symptoms is key. But unless you talk about it with your provider, they're not going to know. Before I started becoming nosy about women's health, even though I thought I was a good doctor, I was surprised at how many things I missed about women's health, and specifically around the part of, the genital urinary symptoms. People are shy to talk about it. So don't be shy. Please talk to your provider about it and get the help you need.
absolutely. And everybody just touch, agree, and pray because Dr. Farooqui knows that SCD just submitted like a huge, huge grant. We're just waiting to hear back. But a huge part of that would be trying to standardize care so that like these reproductive health conversations are implemented into regular appointments so that even if you're not bringing it up, your provider would start bringing it up. So hopefully we get that grant. That question about like the fatigue, I think it's a good segue. And Stacey, I see your question. I'm coming back to it. Sequoia wants to know, she's on here as Star, but I call her Sequoia. She wants to know, is there a way to find out if your joint pain is SCD related or perimenopause or menopause?
So there isn't a way to know. I think the biggest thing is you as a patient have to ask yourself, is this kind of pain that I used to have with sickle cell, or is this something new? Could it be that your sickle cell disease is worsening and that's why you're having that joint pain, or could it be menopause? And that's really the basis of my research. I think we need to look at some biomarkers beyond just symptoms to try and distinguish, hey, is this sickle cell and something that I can do about it versus menopause and what can I do about it? Um, my gynecology colleagues will tell me, if they're complaining of joint pain, we can do a trial of menopausal treatment and
Mm,
see if it goes away. And if it goes away, we knew it was menopause. So, some patients do take that route as well, but we really don't have biomarkers to be able to distinguish between one or the other.
okay.
Yes.
And can you see this question from Stacy? I like this question a lot. What are your thoughts on osteoporosis screening modifications in sickle cell patients in perimenopause or menopause, given the gaps in knowledge and the impact on bone health?
I think one of my colleagues in California is actually looking at osteoporosis, and I really like her work. I do think screening for osteoporosis in general, regardless of menopause, should be changed in individuals with sickle cell disease, including men, because
Mhm.
there are so many reasons for individuals with sickle cell disease to have low bone density, including um, iron overload. So, and especially with avascular necrosis and some of these other conditions, if you've had transplant, we really need to put that. I hope we can at least start thinking about, changing guidelines in terms of osteoporosis management, because you'll be surprised how many of my young 40, 50-year-old patients have osteoporosis and have started treatment. But we have to fight with insurance to get the DEXA scans approved and things like that. For some, we're able to do it, for others, we're not. And we don't want the patients to bear the brunt of the financial toxicity that comes with these kind of testing either.
Right.
So, unless we have national guidelines that are supporting it, physicians and patients are going to have to continue to fight with insurance to get the screening early.
Yeah, I know the hematologist that you're talking about. She's actually done a webinar for us that you guys can find. She did it on bone health. Her name is Bimpe Adesina, and we need to track her down. So we'll try to get her on here for part 2, just to kind of see what her data is showing. Um, can IUD with hormones cause menopausal symptoms?
Is it pause or cause?
Cause.
Cause. Typically, IUDs with hormones, there's a very, very small amount of hormones in the Mirena specifically. That those should not be causing menopausal symptoms. And in fact, my patients who are on contraception, whether it's Depo or other forms of contraception, they actually have less menopausal symptoms. But the amount of uh, hormone in IUD treatment, IUDs, is very low, and it only affects it locally. Systemically, there should not be an issue.
Okay. Um, Somebody wants to know, how did you go about your research? I'm not sure if they're asking how you put the cohort together, or like what made you research it to begin with, but maybe just an overview of the cohort again.
So I'm fortunate. We're at UI Health, where we have over 600 individuals with sickle cell disease. We have 4 to 5 robust sickle cell clinics. We have 5 sickle cell providers. So I had a really good infrastructure to be able to do the research. And we have our patients are wonderful. It's I I think sickle cell warriors are always very interested in wanting to know more and so gracious about participating in research. I really want to thank my warriors from the bottom of my heart that have made this work easy because they want to find answers. So, really, my work was really easy because I had the infrastructure there, whether it was my mentors or my research participants, my research staff. And to answer the question about how I got into this, I never thought I would like women's health research, to be honest with you. And really, it was that one patient that asked me about menopause. And when I was doing the literature review, all I could find that was that one Brazilian study of 20 patients. And I was like, how? There is quite a lot of research on sickle cell. I know it's not where it should be, but there should be more on menopause. So that's kind of how I started.
That's great to hear. So definitely just more, just you're amplifying what I hope all of us already know, that like our voices really do matter and can be incredibly impactful. It just took that one patient for you, and you've made some really, really great strides. So, do you think that an IUD would help as you go through perimenopause?
I honestly don't know the answer to that question. It's a good question for a gynecologist to answer. I would think locally with symptoms of vaginal dryness, maybe perhaps it might help. But I know the hormone that's released in the IUD only stays within the uterus. So I'm not sure if it will
Mm,
help with other systemic symptoms,
that makes sense.
such as hot flashes, mood swings, and sleep disturbances.
Yeah, that makes sense. I think you can see the comments just, thanking you for this research. People are saying, that they've, like you had already talked about, gone to their providers and had questions about perimenopause, but they're often told that there's not enough data. So, really grateful. I think this is, oh, no, 3 more questions. And then we're you go. Um, Wondering if, okay, so Whitney said she's currently undergoing iron infusions, and she's wondering if that would be something to continue leading up to menopause or during menopause to reduce symptoms.
Okay. So Only take iron if you're deficient in iron. If you're not deficient in iron, you don't need iron because your body does a really good job of holding on to iron. And especially in individuals with sickle cell disease, you get a lot of blood transfusions.
Yeah.
Each bag of blood has a pill of iron in it. So you're higher risk for getting iron overloaded, which can cause a lot more problems. So only get iron up to the point where you need it. If you have enough iron stores, you don't need to continue iron. One thing that is unanswered that I am currently looking at is as women bleed, they lose iron. So, what happens in our patients who are already iron overloaded and they stop their menses, especially if they stop it early, they're continuing to get these blood transfusions. Does their iron overload get rapidly worse as they hit menopause? That's something that I have some of my trainees that are looking into right now, and we don't have answers on it just yet. But theoretically, your risk of getting too much iron will probably increase once you stop bleeding from your periods.
Mm. Wow, people are asking like some stuff that I've never even thought about. Any like literature or data to suggest that there's an association with perimenopause or perimenopause and the development of heart arrhythmias?
So, if you look at the Green Climacteric Scale, which is a questionnaire that we've been working with Dr. Odenegi and Dr. Pecker at Hopkins and Duke and UIC, the first one of the first questions is, are you experiencing heart palpitations? So, yes, heart palpitations can be associated with menopause and perimenopause. Specifically, when you're having hormonal fluctuations, you can have arrhythmias. Um, and that's something that is well known and well studied in the literature.
Okay, cool, cool, cool. And I think you did touch, but I know a few people might have come in after the slide. Can you just talk again? Did you find any data or in your cohort, was there, or in the SWAN study, like, you know, how Dr. Pecker was talking about like early age of diminished ovarian reserve, any reason to believe that individuals with sickle cell will start menopause earlier than
So in our cohort, we did find that individuals with hemoglobin SS, the most severe subtype of sickle cell, did undergo menopause several years before the average black female in the United States. And by several years, I mean like early to mid 40s versus 52.
and the 30-year-old that you mentioned, was that SS?
Yeah, we had not just one, but we had a handful of mid to late 30-year-olds that underwent menopause, and that's called premature ovarian failure. So when if you undergo menopause 40 to 45, that's early menopause, but if you undergo menopause before age 40, that's premature ovarian failure. And that's something that needs to be actively managed with a menopause expert because your cardiovascular risk goes up, your bone health needs to be monitored, and there's a lot of things that go into active management if you stopped getting periods before the age of 40 and you're officially in menopause.
Okay. And
And
I
that's also a recommendation where, even the gynecology societies recommend doing testing to make sure that you're not in menopause. And they give the FSH, estradiol, and anti-Mullerian hormone testing specifically to make sure that you're not in premature ovarian insufficiency.
okay. And then last question, and then we can wrap up. So say somebody is on this webinar now and they're a little bit freaked out. They have a bunch of questions. Does it make more sense for them to schedule an appointment with their hematologist? YN.
Or what?
GYN.
GYN. Hematologist. I'm a hematologist. I didn't learn about menopause up until 3 to 4 years ago. We don't really study menopause in our training. We probably have a couple questions on our second year med school exams, and after that, really, we don't really study about it much, nor do we have much knowledge about it. My goal is to hopefully become knowledgeable and not have to send my patients to 10 different specialists. But until then, and until we'll raise more awareness in hematology, I would recommend going to the gynecologist.
Awesome. Okay, well, it looks like that was the last question. A lot of people are just saying they really appreciate the session. Dr. Fasuke is on here. She says, hey. And then, yes. Okay, so this was amazing. We learned a lot, got a lot of good questions out there, a lot of good answers. We're just going to keep pushing, especially from an SC Red standpoint, to, advocate for more funding, more research, more awareness, more education. And I did see a question about how to get involved with SC Red, and that's actually the perfect opportunity for me to plug this new initiative that we're doing. Some of you might have seen that we have just launched this representative program. So I'm recruiting representatives who would come on and like I'm doing now. Like you would host webinars, you'll moderate fireside chats, you'll be leading peer education, you'll be equipped with all that you need to start engaging with state legislators so that we can incorporate some reproductive health changes into the legislation. And so if you go on our social media channels, you can find that application. That is, if you are in the US, we are starting with the US. If you're outside of the US, then, we're always down to collaborate. And if you have some ideas, just email me and we can talk about it. But I thank you all for joining me. We are going to end this webinar and we will be back in the month of April. We'll be doing weekly webinars leading up to Infertility Awareness and Black Maternal Health Week. So I'll see you on this platform in April. And Dr. Farooqui, just thank you again so much for this incredible information. Thank you for doing something different and actually studying menopause. Thank you for listening to your patient and prioritizing their concerns. We really appreciate it.
Thank you, Tiana, and thank you everyone for all the wonderful and insightful questions. I actually learned a lot from the questions myself.
Me too. All right,
All
everyone.
right. Have a great evening.